In this video, let's talk about high-yield pharmacology related to psychiatry. So lithium is our first-line agent for bipolar disorder, but it comes with a lot of side effects, which are important to know. So Epstein's anomaly is when there's apical displacement or right atrialization of the right ventricle. That basically means the tricuspid valve in the right atrium dips down into the right ventricle. So you don't want to give lithium to people who are pregnant. Lithium can also affect the thyroid. So it's important to keep an eye out on TSH and T3, T4 levels as well. So lithium also has a very low therapeutic index. So you want to check their renal function because lithium is excreted by the kidney. Also very high yield to know is interaction of lithium and a couple different other medications. If the patient is taking thiazides, ACE inhibitors, or NSAIDs, that can cause an increase in lithium levels and then causing toxicity. And lithium toxicity is going to present with GI symptoms, so nausea, vomiting, diarrhea, abdominal pain, as well as neurological symptoms. So that'll be like confusion, ataxia, agitation, maybe a tremor. Another mood stabilizer very commonly used for bipolar is valporic acid. And valporic acid is metabolized by the liver. So since it's metabolized by the liver, you want to check LFTs pretty routinely, at least for the first 6 months. Valporic acid can also cause pancreatitis. Thrombocytopenia and alopecia are other common side effects as well. You shouldn't give valporic acid in pregnant women either because it has a high risk of neural tube defects in the baby. Lamotrigine is another mood stabilizer you can use, and with this it's important to watch out for Stevens-Johnson syndrome. Carbamazepine is another mood stabilizer, and again this can cause SJS. Also with carbamazepine, watch out for thrombocytopenia, check your LFTs, and carbamazepine is also tetragenic and metabolized by CYP450. So that's a good segue into talking about CYP450 inducers, which are carbamazepine, barbiturates, St. John's wort, and even tobacco. And some CYP450 inhibitors that are good to know are fluoxetine, paroxetine, duloxetine, and sertraline, which are all SSRIs or SNRIs. It's very important to remember that you don't give someone with bipolar antidepressants because that can induce mania. So before starting an antidepressant, make sure you screen them for bipolar disorder. So our first line treatment for depression is SSRIs. When you start someone on SSRI, the most common side effect people complain about is GI symptoms such as nausea, vomiting. They can also have some insomnia when they first start an SSRI, but then they should develop tolerance after a couple weeks. If they abruptly discontinue their SSRI, they can get flu-like illness. It's also important to remember that SSRIs can actually increase suicidal ideation in young people less than 25 years old initially when they first start taking it, so it's really important to monitor them closely. And it's important to remember that a patient needs to be on the medication for at least 4 to 6 weeks for an appropriate therapeutic trial before trying another SSRI, and they have to try 2 SSRIs before switching classes for depression treatment. SSRIs can increase warfarin levels, so that can cause more bleeding. Specifically, fluoxetine has the longest half-life. So when you're switching from SSRI to like an MAO-I, you need a washout period. So fluoxetine, since it has the longest half-life, it specifically requires at least a 5-week washout period. Citalopram or escitalopram, be careful with QT prolongation or giving this drug to anyone who's had an MI in the past or heart issues in the past. SSRIs can come with a lot of side effects, such as decreased libido and delayed ejaculation. So SSRIs can actually be used for treatment for premature ejaculation. But let's say a patient's having a lot of sexual side effects and they don't want to take an SSRI, you can give them bupropion, which is norepinephrine and dopamine reuptake inhibitor. Be careful not to give this to anyone who has an eating disorder, more prone to vomiting, or history of seizures. You can also give them mirtazapine, for example, which is an alpha-2 blocker. So because of that, it can cause hypotension. But you can also give mirtazapine in patients that are not eating a lot because it increases their appetite if they need to gain some weight, or if they also are having trouble sleeping. Trazodone is another drug you can use for depression. The side effect for this is priapism, orthostatic hypotension, and usually people will give someone trazodone, especially if they need more help sleeping. SNRIs include duloxetine and venlafaxine. SNRIs are great in people who also have like diabetic neuropathy, for example. It's important to know that venlafaxine will cause increased blood pressure, and duloxetine has a side effect of hepatotoxicity. TCAs can also be used for depression if SSRIs don't work. Drugs in this category include amitriptyline, imipramine, disopyramine, clomipramine. But it's important to remember that imipramine is used to treat for bedwetting in children. Clomipramine is used for OCD. Amitriptyline is often used for chronic pain as well, migraines, insomnia. If you have a TCA overdose, you treat that with sodium bicarb. Mechanism of action of TCA is serotonin norepinephrine reuptake inhibitor. Side effects include anticholinergic properties, so dilated pupils, being really hot, having flushed or dry skin. MAO-Is are not very commonly used for depression anymore, but they are a category of drugs that can treat it. With MAO-I drugs, it's important to remember the tyramine crisis. So if a patient is having wine and cheese, for example, in this medication, that'll induce that. They'll become very hypertensive. And also MAO-Is have serotonergic properties, so also a risk factor for serotonin syndrome if they don't have an appropriate washout period or taking other drugs that have serotonin properties. Other drugs to watch out that do have serotonin properties are linezolid, TCA, ondansetron, buspirone. And if someone has serotonin syndrome, they're going to present with sweating, hypertension, tachycardia, hyperreflexia, hyperactive bowel sounds. They're going to have lower extremity rigidity. They can have myoclonus as well. Treatment for this is to stop the medications and give them cyproheptadine. And then the other syndromes that kind of appear similar are malignant hyperthermia, which occurs after someone has had anesthetics. Neuroleptic malignant syndrome is NMS that occurs after someone's had antipsychotics. And if you have NMS, you're going to present again with fever. You'll have diffuse lead pipe rigidity, and will probably have elevated creatinine kinase. Treatment for NMS is bromocriptine and dantrolene. NMS most commonly occurs with first-generation antipsychotics, but it can occur with any antipsychotics. So our low-potency first-generation are clomiprazine and thioridazine. Thioridazine causes like retinal pigmentation, so the R in thyroridazine is for retinal, and clomiprazine, so the C is for cornea. Your first-generation high-potency are haloperidol, fluphenazine, and these are gonna also cause more EPS. You treat tardive dyskinesia with these drugs listed down here. You treat akathisia, which is restlessness, with beta blockers, benzos, and benztropine. You treat dystonia with Benadryl, which is diphenhydramine, or benztropine. Now, for second-generation antipsychotics, again, these block dopamine and serotonin. They have more of a risk of metabolic syndrome overall, especially clozapine and olanzapine are the two that really cause you to gain weight. Clozapine is used for treatment-resistant schizophrenia, and because it has the severe side effect of agranulocytosis or neutropenia, if their ANC drops below 1,500, you have to stop the drug. Other side effects are also hypersalivation, constipation, having an ileus is very common, or myocarditis. Ziprasidone can cause QT prolongation. Olanzapine we talk about weight gain, dyslipidemia, hyperglycemia, sedation. It can also be used for sleep. Quetiapine is another one that's a good one for sedation. Risperidol will increase prolactin with a tubuloinfundibular pathway. All antipsychotics can lower the seizure threshold. And again, all these antipsychotics, because they're bringing down your dopamine levels, can cause some Parkinsonian side effects as well, such as like bradykinesia, rigidity, tremor. So you can treat this Parkinsonianism with amantadine or benztropine. It's also important to remember that dopamine inhibits prolactin. So if you're blocking dopamine, you have more prolactin, which is why a lot of these will have the gynecomastia, increased prolactin side effect. Also, TSH can increase prolactin. So hypothyroid patients, for example, will have more TSH, and that can also induce more prolactin. So let's talk about benzodiazepines. It's important to know which ones are short-acting, which go by the mnemonic of ATOM, ATOM. So alprazolam, lorazepam, oxazepam, and temazepam. Then it's good to know the ones that are not processed by the liver. So you can give this to people who have cirrhosis, alcohol use disorder, anything causing liver conditions. And so these ones would be the ones that start with OT and L. So the mnemonic is outside the liver. So oxazepam, lorazepam, and temazepam. Let's say someone has a benzodiazepine overdose. You should give them flumazenil. Flumazenil is a GABA antagonist. For Alzheimer's, the main drug category to use are acetylcholine esterase inhibitors. So acetylcholine esterase is the enzyme that breaks down acetylcholine. So you don't want to break it down because you want to increase the levels of acetylcholine in patients with Alzheimer's. So the drugs that do this are donepezil, galantamine, and rivastigmine. You can also use another drug called memantine, and this is an NMDA or glutamate receptor antagonist.